Thank you all for joining our webinar today with Raphael Rakowski from Medically Home. We've put up a splash screen here for folks. If you are interested in tweeting or want to follow the tweeting that we'll be doing live from this event, that you can visit us at MaHealthData. If you want to learn more about the consortium, we encourage you to reach out to us at info@mahealthdata.org. We have a range of memberships spanning from a community membership, which basically is complimentary and membership open to the community, right up through members who are working closely to assist healthcare organizations in navigating the world of interoperability, information blocking, price transparency, HIPAA changes to privacy. And we would love to have you join us in those conversations. So if you're interested, by all means, please reach out to us. I think our guest is an individual who is on the edge of great things. One, we know from our first CIO forum of this year that John Halamka, who used to be our colleague at the Beth Israel Deaconess Medical Center, is now in charge of the Mayo platform, their platform for digital technologies that will enable them to harness 130 years of patient data, obviously blinded, obviously separated from any outside activity, but to really look at how to change healthcare. And one of the initiatives that John discussed to us was Medically Home and the work that Mayo is doing with Raphael. And I think I'll let Raphael introduce himself. We are very excited to have this presentation. By all means, if you have a question, you can type it into the chat box, and you can unmute your microphone and ask your question directly. We prefer a good back and forth. Please tell us who you are when you ask your question and where you're from. And we'll get everyone's questions answered over the course of today's discussion. So with that, I will turn it over, Raphael, to you and allow you to introduce yourself, your company, and take it from here.
Thank you so much. Nice to virtually meet everyone. My name is Raphael Rakowski. I'm one of the founders of Medically Home. I will tell you the story, my story, but one of the things I did for giggles is this morning I had a chance to present Medically Home to all of Mayo Clinic. We've been working with them for about 2 years, and John Halamka sends his regards, and I used the exact same presentation to be sure that if it went well, it would go well now. So I give you that as a beginning. So I'm going to just kind of maybe tell you my story, and it's a very, very personal story, and I want to make sure that my screen is on. Is it on, Denny?
It is. We can see it, Raphael.
So my background, I'm an engineer by background and training. My parents were Holocaust survivors, which shaped my life, shaped my thinking, not just in my professional life, obviously in my personal life. And after my engineering career, I ended up running a very large public health company called American Healthways, had some success. We had about 3 million patients in our model, caring for patients with chronic disease. And about 12 years ago, I was joining an academic medical center board. My friend had a board seat, he was retiring. And in the process of joining the board, I decided to keep a diary of my father's care, who had just been admitted there by complete coincidence with a pretty challenging acute issue. And during the time I tracked his care and monitored him and kept the diary, he lost his life from 3 medical errors while I was watching. And that's how Medically Home was born. When I did a typical engineering root cause analysis of what happened, it was the first time that I discovered that 65 to 68% of the cost of care in a facility-based model like a hospital was overhead, and only 32 to 35% was actual care cost, which meant there was enormous financial pressure on the hospital to move patients out as quickly as possible, particularly because they're on a fixed DRG payment. So when it was clear to me that the financial model of the hospital and the clinical model that it was colliding with were not aligned, it became obvious why patients had so many medical errors. There are 417,000 accidental deaths in hospital from medical errors per year. And also became clear to me why we had such growing levels of usage of skilled nursing facilities to quote unquote finish the care that wasn't completed in the hospital, and why we had 18 to 20% hospital readmissions. So those are artifacts of the model. And I said, well, what if we moved the patient home? What if the care site was in an area where patients really preferred? And at that point, there was about 15 years of good quality clinical research, not just domestically, including randomized controlled trials, but around the world, that tested the viability of a home in terms of outcomes recovery for patients with acute illness. And Dr. Bruce Leff was kind of the father of that research at Hopkins, is a very close personal friend and colleague of mine for most of my career. And I went to him and I said, has anyone actually scaled reliably, safely, high acuity care at home? And he said, well, actually, no, there is low acuity hospitalization at home. But if you're talking about a level 3 patient, that's never been done. And the challenges are pretty epic, including, the logistics to get services to bedside reliably and quickly for patients whose condition may change quickly. So the engineer in me, and obviously the righteously indignant person in me after what happened to my father, I decided we were going to build this and build a new care model. The model had the following elements. One is it would be at home, and we center the care around the patient and the family, not the hospital and the payment. Secondly, we would extend the length of stay to reflect what it took to get the patient to a clinically stable endpoint. So instead of a 4.5-day length of stay, we decided to keep the patient for 30 days and in effect, fuse together what today is acute care with what today is post-acute care and what today is community-based population health or population medicine. So a single episode that encompassed all the things the patient needed to not only be clinically stable, but to reliably avoid another episode. The third element was, apart from the home and an extended length of stay, to ensure that the patient had a single care team and didn't transition and get handed off, because one of the most caustic parts of degradation of patient engagement is the constant transferring and handing off patients from one provider to another. So that was in my head, and nobody would fund it. So we funded it ourselves. And for the next 5 years, we built out and designed this model, which ended as a clinical trial in Chicago, which we partnered with Advocate Healthcare and Johns Hopkins Medicine. We published it, and we showed that we could safely take home a significant percentage of patients at high acuity, care for them at home by combining a virtual care model where we centralize clinicians in a command center and a field level clinical model delivering care to patients on demand in the community. And our first patient was in Boston with Atrius Health. Steve Strongwater, the CEO, is also a colleague of mine. And our first patient, Chuck, is kind of the beginning of the story. So Chuck was 92, had cancer, pancreatitis, pneumonia. He was legally blind and legally deaf. His roommate, who's younger than him, was psychotic on a Valium taper. And every possible social determinant and challenge to Chuck's life and recovery was in place as our first patient. And we were with him for 42 days. He had been hospitalized 6 times previously, very, very previously, as in the previous 18 months. And once he was under our care, he was never hospitalized again. He went from the highest cost patient in the Atrius system to the lowest cost. And a lot was learned, particularly around surrounding him and his family with care. And the economics of Chuck's care were actually pretty stunning. There was a 27 to 30% reduction in cost. If he had gone to the hospital and the care that followed, he would have had a much higher care cost. So all of the outcomes checkboxes were made. And then our work with Chuck was found out by Mass General in Boston. They were about to start a clinical trial for stage 3 pancreatic cancer patients that was very aggressive and involved chemotherapy, radiation, and Whipple surgery with a very, very high dropout rate, death rate, and obviously hospitalization rate, because the therapies were aggressive enough to cause the need and the use of the hospital. So we took on that clinical trial, and we basically enrolled those patients into our program for 6 full months. And the outcomes were just completed it was 2 years ago. We just finished that, and that's been, I guess, in the process of being made public. And they're stunning, just like in the other work that we did. And then a lot else happened, but the quick version is pandemic hit. And when the pandemic hit, hospitals, as you know, were full. We're trying to decant patients out to create more capacity. And then we really mobilized and started to move non-COVID patients home to make room for COVID patients. And then we started moving patients directly from the ICU in the step down to the home, as opposed to clogging out those med-surg beds. And then Mayo Clinic and John and others approached us about partnering. We engaged and then worked very closely with CMS and CMMI to get a reimbursement structure enabled for this, which we did. And then a whole bunch of other things happened, which I'll cover at the end in Oklahoma in rural care. But the 12 years that I've been involved with this, beginning with my father's experience all the way to now, has been an extraordinary journey in persistence and a recognition that the model for care delivery, not just hospital care delivery, needs to be rethought. So I think I've covered what the challenge is for the current hospital model. Its entire structure is based on the premise that we need to centralize the providers and the equipment and take the decentralized patients and bring the decentralized patients to the centralized model. And it's very similar to the thinking of how Amazon changed retail. How do you take the centralized function and create a decentralized delivery model? And that's at the heart of the solution. At the heart of the problem is hospitals do not have flexible capacity. Many are overloaded and need to build new beds. Many are underused and struggle financially. And all of that in the face of rising hospital costs and changing preferences by patients really demands a look for a new model. And then what really drove things, I think for us, is this new phenomenon, which began roughly in July and August of 2020, which is patients are afraid of going to the hospital now, particularly older patients and particularly family members of older patients. And that's dropping ED volumes across the country, in some markets as much as 50%, on an average of 10 to 30%. And hospitals are now concerned that the front door of their hospital, which is their ED, is under threat from new models, new entrants, new disruptors, and they're trying to figure out how to disrupt themselves so as not to lose the funnel of patients that they used to be able to reliably have and grow year to year. Technology is growing, allowing more decentralization. The whole mood around decentralization is growing. The home as a venue of care is a theme around just about every private equity firm that's funding healthcare. And obviously, there's been a movement to value, but not as aggressive as I think everyone hoped. But with the new stimulus bill and all of the money that's going to go out the door from our economy to basically repay the economy for all of the losses as a result of the pandemic, is going to drive CMS to really force and accelerate an amplification of value. And we're going to see that, in hospital systems are seeing it and now recognizing they better put more than a toe in the water to really get ahead of their ability to move from fee-for-service medicine to value. So all roads are now leading to the home, which is really driving what we do. Of all the things I hope you remember about this presentation, this is the most important part. And I want to make sure I take my time and open up to questions because this is the heart of the matter. In a typical hospital, you have a range of acuities from very low to very high. And very high, you can imagine, is the ICU level patient. And they are really not a candidate to go home. They're highly unstable and they need an enormous amount of 24/7 care. On the low end, patients there may not be admitted. They're in the observation unit in the ED. And then as you move up this acuity continuum, what you see is in the low, medium hospital home programs that are now proliferating, not just in the US, around the world, France, Spain, Australia, parts of Latin America. And it's basically taking a low acuity cellulitis patient, someone with a low acuity pneumonia, younger patients home that requires some hospitalization, maybe some IV infusion, take them home, have a physician house calls for 2 to 4 days, and some scheduled nursing visits. That's not our business, and that's not an area of interest to us. What we were more interested in is the high mediums, which are the patients that are just coming out of the ICU, or they're unstable, but the course of their care is predictable, and they required rapid response. And this acuity difference I highlight in this slide. So a typical lower acuity patient has a shorter length of stay in the hospital. They have very little comorbidities. They have very low probability of being readmitted. In terms of categorizing them, their severity of illness 1, and less than 10% of them ever get readmitted. The patients we're interested in are much more complicated. They have multiple comorbidities. They have high likelihood of being readmitted to the hospitals, and they require an enormous amount of services during their acute episode. And the best way to think about left versus the right, is the left side patients represent in the US 5 to 7% of patients currently hospitalized. The right side represents 30%. So if you have an interest in creating a hospital at home program, the key is what are your volume expectations? If they're low, the left side is fine, and a lower acuity hospital home program is absolutely fine and perfect. In fact, if you have higher volume expectations and you have a more provocative thought process around what you want to do with patients, you have to move to the right. The moment you move to the right, there are significant clinical model expectations and changes required. There's technology changes, which I'll cover, and there's an entire logistics layer that the right side requires that the left doesn't. So this slide is a really good way to highlight this thought. So we took a number of our patients that are lower acuity, that's in blue, and then we compared them to the higher acuity. So these are severity of illness 1 versus 3. And you could see during the course of their care, our model, our 30-day model, has patients in what we call an acute phase, where they're typically still unstable, they require IV medication, their vitals change, and they move into the post-acute phase, which we call restorative, which is typically 20 to 30 days. So the number of touches that SOI1 patients have, as you can see on the left, are 42 compared to 75 for the higher acuity and 44 versus 146 for the restorative care. It's a really significant difference. The length of stay is 7 days for the acute phase versus 5, which means they didn't get stabilized for at least 7 days. And the length of stay, as you can see, for the acute and restorative phase, dramatic difference. But look at the costs. The cost of care for a low acuity patient is under $4,500 versus north of $9,000. So the cost of care is significantly higher. So when you look at acuity, if you don't look at acuity, hospital home programs could look alike, but in order to handle this high acuity care, there are significant model implications, and I'm going to go through that now. So the heart of the model was inspired by work I did in India and in the military, and it's really based on the premise of four legs to a stool. The first leg is a high acuity patient requires 24/7 care management. The attending clinicians need to be looking at that patient around the clock, available and dispatchable around the clock, which means you need a medical command center. So the medical command center is staffed by emergency room docs, hospitalists, intensivists, nurse practitioners, nurses, and a function we call service coordinators that ensure that the orders of the physicians are actually executed as expected. So that command center is centralized and allows us to manage patients elsewhere and decentralized. In Boston, there's a big one in Kenmore, which we operate, and Mayo Clinic and our other customers around the country operate about 8, 9, 10 other command centers, and we're about to open another 5. And these command centers are allowing not just us, the clinicians, managing the patients remotely, but importantly, the patient and the family has access to their clinical team on demand 24/7. So that is a very unique part of the model. If you have a patient in the hospital today and they want to talk to the doctor or the nurse stat, good luck. So second part of the model after the command center is the tech that goes in the home. We've curated all the technologies that we need to safely integrate our ability to monitor and manage vitals, have communication, reliable communication back and forth with the patient and the family, emergency response systems, durable medical equipment, vitals monitoring, both real-time and intermittent, backup power, backup cell signal, supplies, and medications. All of that is set up in about 40 to 45 minutes in the patient's home once they're admitted in the program. And you can think of us taking the patient's bedroom and turning it into a temporary med-surg room in a hospital. So you have the command center operating around the clock, and you have this tech in the home. The third and most important are all the services that you see on the right that have to be organized and integrated and dispatched on demand to the patient's home. Everything from a paramedic, IV access, x-rays, echoes, stat labs, meals, skilled nursing, even physical therapy, speech therapy, anything the patient requires has to be integrated and dispatchable on demand, on command from the medical command center. So you have the command center, the tech in the home, and you have this dispatchable, mobile series of 18 services that go to the patient's bedside. And last but not least, all of this has to be managed with a software platform that allows this thing to operate as a full integrity virtual hospital. However, it has to integrate with the native electronic medical record, which in most cases is Epic and Cerner, which means we have to be completely interoperable. So the physician customer of ours writes an order in Epic, we have to be able to ingest, pull it, and execute that order inside of our system. If the physician writes notes, it has to go into us so we can access the relevant part of those notes to be able to drive the way we deliver the care. In reverse, anything that we actually do in the field has to be billable back into the native electronic medical record. So the platform that we use is called CESIA, C-E-S-I-A. We built it ourselves, and shamelessly, I named it after my mother. We input patients into the model many ways, more than the slide shows. But if the customer has an ED, which many of our customers do because they run hospitals, we can triage the patient in the emergency room. The patient's given a choice of whether they want to be hospitalized upstairs or be hospitalized at home. If they choose to be hospitalized at home, and about 85 to 92% do, we take them home and set up their home as I just described. We also take patients out of urgent care, PCP clinics, patients that are homebound, that are on service. We can actually send an ED to the home, which we do, and I'll cover that in just a few minutes. And we work them up at home, and if they meet criteria for hospitalization, we actually admit them from their living room to their bedroom, and they never leave their home. All of the services and systems that the patient gets once they're admitted mirror identically what happens in the hospital, with one big difference. We're not in a rush to care for them quickly like we are in the hospital. And a good example of the difference that presents is a patient with heart failure. In a typical hospital stay, will get a very high dose of Lasix to start to reduce the water load on their heart. And we don't do that fast because it actually creates pressure on the patient's heart, and we do it much more slowly because we have the time to do it slowly. There are many other examples of how the care is actually changed because we don't have time pressure on our side. This is a picture of our command center, and basically, I think I covered this. It's 24/7 operated, tethered to the clinicians in the field. It's operated with the software that we built, and it has a seamless relationship to all of the patients in the field and all the providers in the field. These are the 18 services that I referred to. This is a logistics issue. So anyone who's ever tried to do high acuity care, and the many programs around the world that are doing hospital at home, the moment they tried to do a level 3 patient, and the moment they ordered oxygen or an infusion nurse or labs or a stat x-ray, the moment that didn't happen the way they ordered, that was the end of their high acuity hospital home program. Without physician confidence in the model, the risk to the patient and the risk to their own license is too high. So the line in the sand between high acuity and low acuity is logistics. So enabling all of this requires a completely different system of care, which is what we've spent all our time building as geeky engineers. So how did all of this come about? It was inspired by two ideas. One was the military, which I think I referenced when I started, and the other was by a clinical model in India. And the military model has been going around since the Korean War, which is, it's military logistics. Put a medic in the field right near the soldier when the soldier gets hurt, connect that medic in the field, put equipment on the field, on the actual soldier to be able to access to care for the patient in place, and connect that to a command center and have basically the central intelligence of medicine centralized and managing the field level medic, which is a low level clinician. That idea of field level clinicians with lower license, enabled with technology, connected to a command center that has all of that know-how, that's the heart of the idea that I relied upon when I first started in 2008. And the one in India was intriguing. It was a very rural part. I was working with the Ministry of Health, and it's a very rural part of India where they don't educate girls. And finally, they got a grant to build a schoolhouse, and the teacher that was hired to educate the girls was a midwife. And now you had a midwife teacher. So if a woman came in, her water just broke and she needed to deliver a baby, she said time out to the students during their geography lesson, and she delivered the baby and then went back to being a teacher. But they also gave her a cell phone that was connected to a command center in Mumbai. And that cell phone basically had all the basic protocols of how to diagnose an ear infection, a sore throat, pneumonia, et cetera. So she was also the primary care physician. She was the midwife, and she was the elementary school teacher, because they didn't have any other resources in that area. And I was so inspired by taking what you actually have in the community and transforming it with technology and connectivity into a command center. And those are the two things that actually inspired the model. I think I covered this. These are all the tech components that are in the house. We do real-time monitoring, vitals, in both intermittent and real-time. We have a platform that we built on a iPad technology platform that allows the patient and family to monitor all of their current status, monitor where the services are, when they're coming, monitor when their meals are coming, allows them at the push of the button to look and talk to their medical team around the clock, and all the patient education for the families are enabled as well.
Raphael, we have a couple of questions that have come across the transfer.
Sure.
A lot of hospitals in Massachusetts, and I'm sure across the country, don't necessarily use Cerner or Epic. We have a big base here of Meditech hospitals. Are you seeing other medical records or other EMRs being represented in some of the organizations that are coming to you, or are you looking pretty much strictly at Cerner and Epic?
No, we're agnostic. We can interoperate with anybody. We are completely agnostic. We are, and I'm going to cover this at the end. I'm working heavily in rural parts of Oklahoma now, and pretty soon in rural South Carolina. There's no Epic or Meditech in the community. In the hospitals, there is a lot of Epic, but in the community, there's no Epic.
Right.
So we're seeing a lot of different systems, but even outside of Massachusetts, Denny, most customers are on Epic and on Cerner.
Do people have to be officially homebound, as insurance companies might define it, in order to get evaluated for this kind of program?
This has nothing to do with being homebound. These patients require hospitalization. They need to meet Milliman or interqual criteria for hospitalization. And if they walked into the ED, they're going to be reviewed whether or not they meet criteria for admission. We use the identical criteria. There's no difference.
And lastly, are those initial evaluation services, those happen face to face, or is it possible for, an individual to be evaluated who is ill outside the hospital setting, for example, in a physician's office, and bypass some of the ED, the classic entryway to the hospital?
Yeah,
other ways.
Yeah, as I think I mentioned, I went through it so quickly. I apologize. We admit patients from the ED, from the med-surg floor, from the ICU, from urgent care, from the PCP clinic, from the home. Patients who are scheduled for surgery, Denny, we admit them before the surgery, and then after the surgery, we take them home. We admit patients in a clinical trial from the clinical trial site and care for them for 6 months. So there are about 8 entry points now into the model.
Finally, how do you ensure, we have several here, what does authorization for this kind of service look like? What does a hospital or health system have to do in order to secure authorization for this kind of care?
When you say authorization, Danny, you mean from the payer?
From the payer.
Well, it's typically done retrospectively. So these patients have to meet criteria for hospitalization. Now, when I go through some of the other uses that we're going through, we're now doing ED at home, and we hit our 1,000th patient yesterday just in Boston. So the simple rule is if the patient meets criteria for hospitalization or any model of care as if they were in the hospital, we use the identical criteria. So from the payer's point of view, if you don't meet the criteria for DRG, you will not get paid. It's that simple.
Right. Thank you. We have one final question. How do you ensure evidence-based care is delivered? For example, the rate of diuresis for heart failure. How do you ensure that you're delivering evidence-based care?
Every protocol is provided and collaborated on between us and our customer. And our customers are Mayo Clinic, MGH, the very, very top of the clinical pyramid. So it's not like we tell them how to diurese a patient. They have a very strong point of view. It does vary, Denny, from system to system, depending on their orientation, even in the area of oncology. But the protocols and the approval and the collaboration is done with the medical advisory board in close cooperation and partnership with our customer. We're not telling them how to practice medicine.
Okay, and lastly, have you encountered hurdles with respect to medical malpractice insurance carriers?
No, that's one of the most interesting things. The first carrier that I worked with, which was in Chicago, which is, in Cook County, which is the most litigious med mal county in the country. There's nobody that's even close. And when we went with the underwriter to look at the model, this is before patient one, his conclusion was, this is safer than the hospital because you don't have MRSA at home. Fall rate is lower. I mean, he went through the list of things that are at risk, and the risk of actually not getting to the patient in time, and the response to that risk is the ability to escalate and transport back to the hospital. So he said, at the worst case, I'll give you the identical rates as the hospital. And as the model has gained favor and more data, I imagine this is going to be a lower cost model from a med mal standpoint. But there will be events, unfortunately, as life has. So far, we've been very fortunate. But
right.
From a med mal standpoint, there is no additional exposure as we sit here today.
Okay, well, thank you.
Welcome. Okay, so this is the architecture for the software. I'm not going to go through it for three reasons. One is we don't have enough time. Two, I hate to go through this and see you guys are in the IT world and I'm not. So I'm not going through it. But suffice it to say, the model of Sasha allows us to accommodate and integrate all the key elements of how we create a standalone virtual hospital that has to interoperate with the host EMR. It's everything from the data that we ingest in the home to the coordination of the care, to the actual response system of how we pick the vendors, how we contract, how we actually bill, everything we need in terms of the interaction with the patient off of that tablet, and then all of the analytics that allow us to be able to demonstrate that the outcomes are there and that the safety is there. So this is another really important slide. I covered the line in the sand between higher and lower acuity. And let me take a moment and really set this up for you correctly. So technically, we're not in the hospital at home business, although everyone knows us as high acuity medical care at home. We're in the business of creating a new delivery platform and chassis. And this is where John Halamka and I met, deliciously from the very first conversation. He had the identical vision that we had, and so did, John Rico Fallujah at Mayo. The idea that we've built over the last, 100 plus years, a platform of care that's designed around the provider, the facility, and payment, shifting to designing a platform of care around the patient in the home. That's a kind of a revolution, an asset revolution, and a delivery model revolution. If you successfully transverse this revolution, where you end up with is a new platform. If you have a 24/7 rapid response supply chain, if you have a command center operating around the clock, if you have tech in the home, and you have software, there's no reason why you can't do primary care in the most rural parts of the world 24/7. There's no reason why you can't make the most competent specialists available to patients around the world 24/7. There's no reason why you can't do high acuity ED at home anywhere 24/7. There's no reason you can't do NICU at home for patients in the last 7 days of a NICU stay. And the list goes on and on and on. So what we've built from day one is a chassis to handle the conversion of the existing delivery system to a delivery system that's decentralized. That's the business model from day one, but we've been known as the high acuity medically home guys because we wanted to first demonstrate that it works at the highest acuity level first in order for us to be able to safely expand to these other use cases. So that's the premise behind the company. In terms of the value proposition, the three key stakeholders, the health system bills for this. The savings are pretty significant versus the current cost of care, but there's also a revenue difference because today the hospital bills a DRG, let's call it $10,000, and they're not billing for the care that follows. Now there's a bundle that goes to the payer and they go, we'll take responsibility for 30 days for that patient and we'll bill you $13,000. So their revenue goes up. The savings are significant compared to the way they're delivering care today. So they make a margin on the savings and they make a revenue bump. There's new revenue also because they're now able to reach patients outside of their footprint and deliver care outside of where their bricks and mortar hospital currently resides. There's fewer quality-related penalties. If they are full, and a lot of our customers have full hospitals, they want to unclog those lower acuity patients, get in the higher acuity, and obviously the surgical patients in, and improve their case mix index. And if they are, considering building new beds in a new tower, and let's say they need 10 or 15% more capacity, at $2 to $3 million a bed, there's a significant savings, expanding capacity virtually compared to building out new towers. From the payer standpoint, the meetings are very quick. You had us at a low, you save us money, patients happy, employers are happy, and the payer or the risk bearer has been the easiest part of the model. And lastly, patients, their families, we are blessed by all the feedback. We've changed so many lives. We've saved so many lives by keeping patients home where they want to be. I already covered that. So this is fairly recent and relevant to Massachusetts. So about 8 months ago, Evan Berg, who ran the ED at Mass General, came to me with this idea of high acuity emergency department medicine at home, and had a vision of putting these paramedics in the field, tethering them to our command center, staffed by ED docs, and equipping the vehicle at a higher level to be able to enable this higher level care. We've done this with Atrius, and now it's expanding in Massachusetts. And as I said earlier, from a dead start, in just 8 months, we've now treated 1,020 patients as of yesterday. And all of the learning is, as of yesterday, our average acuity level of patients treated in the field at home is higher than than Boston General's hospital acuity level. So we actually have sicker patients on average that we're caring for at home than in the bricks and mortar hospital in Boston. So this is kind of my last piece soapbox, which is right now, when a patient shows up in the hospital and they need to be hospitalized, the default position is, oh my goodness, this patient's sick, they need to be hospitalized. That's the standard of care. For the right patients and the right acuity levels, which I've covered, our view is we need to change the standard of care to the home. And only after the patient fails to be safe at home, for whatever reason, then we can go to plan B, which is the hospital. That mind shift, I'm working my brains off with Hopkins and John and the team to create this mind shift, which is, if you're the admitting doc or you're in charge of the command center, your mind shift has to be, the care standard needs to be the home. And the evidence, which is 25 years old, and all of the data that now supports this, says this is a way to look at the model and the market completely differently. But this is what I proselytize more than about anything else. And I didn't have the last slide in here, but it's what the work we're doing in Oklahoma. Let me spend a minute on that and then open it up to questions. So about 8 months ago, I was invited with the George Kaiser Family Foundation in Tulsa to look at the way in which we could create a highly national scalable model to deliver care to basically low-income Medicaid, underserved patients in the most rural parts of the state, and develop some very strong points of view about the challenges in rural Oklahoma. Oklahoma's 50th in the United States in terms of quality and outcomes of all the states in the US. So it's a very low bar. And we developed a very provocative model to take our platform, our chassis, to not just a substitute for the hospital, not just a substitute for the ED, but to change the way primary care is delivered and made available to patients around the state 24/7. We've raised about $15 million of grant and philanthropy funding, and we are launching this program. And as a result of that, we've got inbound interest from 2 other states. One is South Carolina, the other is Puerto Rico, and 2 countries, because this rural health dispersion of population challenge is a pretty common problem around the world. And we're terribly excited. I stepped down from the CEO role of Medically Home in June of last year into the chairman position. And now I've been doing this rural care initiative full time, and I'm loving it. But this is the next kind of big development for our model, which is not even to talk about hospital at home. It's to talk about reconfiguring the delivery system for rural America and rural communities around the world. Anyway, I'm done.
Well, that was fantastic. We have a lot of questions coming in. And, I have a number of questions myself, but let's talk about some of the areas where hospitals and their capacity come into play. So for example, imaging, advanced imaging. how do you incorporate the need for advanced imaging and the use of, MRIs, CT scans, and the like in a model where the patient is further from those technologies than they might otherwise be?
Yeah, so today, I'll tell you about today and I'll tell you about 6 months from now. Today, we use an incredible technology for advanced imaging. It's called the car. And we put the patient in that technology and we drive them to the MRI. And it works every single time. And it's remarkably reliable and predictable. So that works today. There are MRIs and CAT scans on trucks, but it's not cost effective to ship a 40-foot tractor trailer with an MRI to a patient's house. Tomorrow, 6 months from now, I've been working with 3 different companies who have advanced imaging. It's based on a sonogram technology with enhanced software that gets you to a resolution that's very, very close. And it's pretty remarkable. And I imagine we'll be in the field with that probably by February of 2022 with advanced imaging portable, where the actual tech, the hardware sits on the patient and the signal is interpreted at home base in the command center. And we're working with a number of companies on that. But today the solution is a car.
And they don't necessarily have to drive the car themselves. If they're
we when a patient's under our care, we do everything for them.
You do everything.
They're in our care. Yeah.
Some homes aren't safe places. How do you deal with the safety issues that might be in a home for someone who is sick? Or
three answers. Yesterday, Denny, today, and tomorrow. Yesterday, we excluded them. We basically had we had and have very strict exclusion criteria. It's called social exclusion criteria. So if there was opioid use in the house, if there was gun violence in the house, if there was no hot water, no electricity in the house, if there was family violence in the house, et cetera, patients were excluded. That was yesterday. Today, by the way, if they were hoarders, we excluded them. Today, a lot of those criteria have been loosened because we've been successfully able to care for a lot of those patients that were excluded. So our exclusion used to be 15% of the patients. It's down to 8%. But tomorrow, one of my obsessions is respite care. So I've worked with churches, I've worked with hotels on this idea called Care B&B. And it's basically, we'll take a site like a church, which is where hospitals began 150 years ago, and pay them $100 a night for a bed. And we'll send our patients there because they're not safe enough at home. The community has churches. There are churches everywhere in the United States. You name a zip code, I'll tell you how many churches there are. I'll tell you if they have internet access or not. So we're looking at churches, we're looking at motels, and we're also looking at this respite idea of a Care B&B model, like an Airbnb, almost like a bed and breakfast to care for patients whose homes are not safe enough.
What about family members? How did they get brought into this new hospital at home? I mean, you've got a whole team working around the patient. What role do you ask of the family, or what expectations do you have of family members?
It's one of those areas, Denny, that is so interesting, and I'd say culturally sensitive. So, I've lived in Boston, and I know the people, I know the culture, and I'm now in Native Americans in parts of Oklahoma, and it's different wherever you go. There are cultures where the family members feel that they want to do it and they're obligated to do it and they actually love to do it. So in those, they're swarming all over the patient. They're actively engaged. They call us day and night, ask us questions, and they could get a medical degree for the amount of time they're interacting with us. They want to become knowledgeable of everything about their loved one's care. And they learn things about diabetes, heart disease, COVID that they never knew before. And we know, those of us who live in Boston, we know those families that are very close that think that way and do that. There are families where there's nobody home. And if there's nobody home and that patient's at risk, we'll provide a home health aide and actually support that patient when that patient's vulnerable. Typically, for just about all of the patients that we care for surgically, we insist on having a home health aide for at least the first 2 days to manage fall risk, as an example. It really depends. If that patient is not safe at home, Denny, before they had an acute episode, they're probably not going to be safe with us. If they were safe and they just needed some home health aid support, we'll provide it. So it's all over the map, but I would say the issue of overburdening a patient's family with the care model is real, but it represents between 3 and 5% of the situations we actually encounter. So when someone says to us, what do you do if the family member is exhausted and they don't want any burden anymore? send the patient to the hospital, or we'll gladly provide the home health aides to give them relief. But it's not a significant challenge. It's not in the 5% range. It's sub 5, but it's real.
Thank you. We talked. I mentioned at the onset of our discussion, sort of this interoperability revolution that is just starting, and over the next 20 months, every hospital, every physician, every health plan is expected to be exchanging clinical and administrative data with each other at a level and a level of standardization, a level of frequency and currency, and a level of breadth that has never been the case before. Are you looking at Cesia as being able to be integrated as part of the patient's chart? Is it become a node on the Epic network, if you will, or are you running into challenges when it comes to integrating with the systems that are at the mothership?
We haven't had any challenges integrating. I mean, it's just interoperability. But if you're asking me, like, what's Epic's long-term vision? They're trying to get into hospital home. They've tried now 3 times. The issue with hospital home is not the record; it's the logistics of getting the medication there in time. And they're not in the business of being in logistics. They're in the business of software, clinical software. So I am working very, very closely with Cerner in Oklahoma, because Neil Patterson, who founded Cerner and who's CEO, passed away recently, early, very unexpectedly, and he left a great deal of money to Oklahoma State University, and that endowment is part of the work that we're doing with Cerner. And Cerner, he was the CEO of Cerner, and OSU are very, very close. So the interoperability challenges in the community, mostly the community-based PCPs, community-based workers, that interoperability is new work for us. But the interoperability between SEISA and the host electronic medical record used to be a challenge. It isn't anymore. But I suspect what's going to end up happening is the supply chain piece of SEISA, which is significant. People are going to recognize that's one of the key elements that differentiate us from everyone else around high acuity. I would guess there'll be pretenders to come very quickly, because you can't do high acuity care without it. So therefore, people will start to look at that very carefully. But we have about a 2 or 3 year head start, and we have Mayo as a partner and others. So I love competition, but I think that's where the real competition is going to come, is around the logistics.
Let's talk a little bit about scale and about capacity. You have a command center. How many patients can a command center manage on a per physician or per licensed caregiver level? What does it look like compared to the old-fashioned model?
Yeah, the simplest way to think about it is, as you start off, you keep the ratios very similar, which is 15 patients to 1, in the beginning, because doctors and nurses are really nervous about high acuity care at home, and they have to get used to it. They've been trained having control of the patient in this facility. I'll give you a classic example. A hospitalist that's been, in Mass General or anywhere in Boston, they write a medical order for anything. They're not concerned that order is going to get executed. It's not even on their mind. Now they have a patient that's somewhat unstable. They write an order. If that order doesn't get delivered, when they go home, it's, that's a really big deal. So the scaling and the ratios are related to the confidence level as the model gets used by the clinicians. All of the data that I've seen, just in terms of, Denny, pure productivity, we could move, because remember, we're managing a patient in low acuity and high acuity. So as they go from this acute phase, where the first 3 days, it's a very intense amount of care, the ratios are actually look more like 10 to 1. Just like in an ICU, as you go up in intensity, your ratios collapse. It's the same for us. As we're in the restorative phase, the ratios go up to 30 to 1, because we're only dealing with the patient post-acute. On average, and this is a lot of the work we're doing with Mayo Clinic, as the data presents itself, the staffing and the algorithms that support staffing based on the clinical status of every patient will drive ratios in real time. But as you sit here today, it's safe to say for the first year of the program, ratios are very similar. And as they progress, they accelerate and increase, giving you more productivity.
At the peak of the pandemic, some hospital systems or major hospitals, and I'm thinking of Houston Methodist in this case, they decentralized and their intensive care units. You know, you're seeing this move to decentralization because the peaks and valleys, the demands on capacity, the sheer, you know, volume of care required a model that had more, that provided more access and more leverage, if you will, for clinicians to care for patients who couldn't get into the ICU but needed intensive level care. Do you see yourself moving up in intensity as the technology improves, as the confidence in the model improves, as the logistics you described improve? Do you see yourself moving further up the acuity scale?
Yeah, I'll give you one. The answer is yes. I'll give you an answer with an asterisk and an enormous amount of caution. I lost my father to a medical error, so all I think about, I'm obsessed about, is patient safety. And every time I think about moving anywhere closer to the highest acuity, you can just imagine what happens inside of my own stomach. So the NICU example is a flagrantly perfect example. So I've been studying NICU care around the country for about a year. And Michael Apkin, you probably know Michael, he was CEO of Tufts. He also ran CHOPS, he ran Yale Children, and he ran the Children's Hospital in Toronto. And he's a close friend and a colleague. And I've been collaborating with him on this for about a year. The NICU is the most prolific profit center of a hospital. There's nothing close. The daily rates, the per diem rates of a NICU are exorbitantly high. It prints money, and every day a baby's in the NICU is a profit center. So there is no huge pressure to reduce length of stay on NICU babies unless the hospital's full, in which case they want to create more capacity. But if the hospital gets full, it's the easiest thing for the board to say, let's build another 10, 20 NICU beds. So we studied that, and I picked basically 30-day NICU babies as my target of interest. My twin boys, one of them was a 30-day NICU baby, my son Brandon. If you look at the last 7 days, Denny, these babies that are there, I'm not talking about congenital disease where they're really sick and they're going to be probably sick and in and out of the hospital for the rest of their life. I'm talking about babies that are feeders and growers. They're immature, they were preemies, and during that last 7 of those 30 days, they need to be supported for nutrition, they needed support for oxygen, temperature, and phototherapy. Those 4 can easily and reliably be done at home. However, the monitoring has to be supremely accurate. Because if you're off on the baby's temperature, because when a baby's temperature can compensate, they can die very quickly. Temperature management of a baby is a serious matter. So I believe firmly that we could manage the last 7 days of a NICU stay for about 80% of American babies in NICU. That creates an enormous improvement to the quality of life for the baby and the family, and an enormous amount of savings for whoever is paying for that care. So that's a classic example of moving up the acuity. And I'm convinced we can do it. And the way we're going to do it initially, Denny, is we're going to actually do it in the hospital. So we're going to basically create the entire model that would have been delivered to the home, stick it in the hospital. So if anything goes wrong, the baby's in the hospital anyway. You follow? We're basically creating a mock home in the hospital and just see what kind of failures the system generates, if any. One example. Second example, transfusions, chemo at home. So we make patients that are highly immunocompromised in the middle of COVID go to the hospital to get chemo and transfusions. And the stories are pretty horrific of what's happened to cancer patients over the last year in Boston and beyond. So that's another area I'm obsessed about, is doing transfusions and chemo at home. And the argument that the oncologists make is, oh, it's just not safe. Well, the truth is the margin they make on 340B pricing for chemotherapy is so obscene, it's like the NICU. The real truth is whatever reaction the patient's going to have to the therapy, they'll have it the first time, the second, and the third time reliably. So we could, no way, no how, no problem, take care of the patient in the hospital for the first dose. But we watch what happens during the second dose. And by the way, after the second dose, predictably, the patient will react pretty much the same. So chemo at home, transfusions at home, NICU at home are just a few of the examples of moving up the acuity scale. I'm committed to do that, but safely, methodically with our customers. And Boston, our command center in Boston, that's the R&D site for our company. So all of these new use cases I mentioned are being done in Boston.
The delivery system itself as a structure with this kind of disruption this kind of dramatic change in what constitutes delivery for a substantial number of what used to be the inpatient population. What happens, the brick and mortar health system is going to undergo a dramatic change. When you look at the big hospitals, the Mayos, the MDHs, what are we talking about? A big ED, a big surgical and intensivist suites, and
I have
a door to the home. All right.
I have a polite and politically correct answer, and I have the real answer. Which one do you want?
I'll take the direct one first and the polite one after that. How about
the direct one is that's why Darwin was Darwin. That's why he was who he was. It makes no sense. It makes no sense to financially support at the expense of taxpayers, community residents, the healthcare systems, brick and mortar facility-based systems that are not sustainable. It makes no sense. And the cost to the economy of doing that and how it trickles down to education, military resources, the tax on inefficient facility-based care is about $200 billion a year and growing. So the Darwin answer is we have to restructure. So I'll give you, Denny, a very precise example that's a microcosm of how you fix this. So I'm in the middle of southeastern rural Oklahoma, and I've become an expert in that part of the world. And I've been in Podo, I've been in Atoka, all these very tiny towns you've never heard of. Every one of them has a critical access hospital. And by law, you can have one so long as there's nothing available within 30 miles. Average daily census is between 2 and 7 patients with 25 beds. Average costs are $1.5 to $2 million a month. Staff of 200 to manage 5 patients. So you tell me who's getting screwed because we're spending all that money there. So the answer is everybody's getting screwed. So what do? One of the hospitals in Eufaula closed down a few months ago. I'm reopening it, and I'm putting in a super ED. And the ED is going to be connected to the top ED docs in the country, managing patients in that community through that ED. But there's no med-surg floor. There's no med-surg patients. There's no meals. It's a super ED. That's one conversion. Second, there's another hospital that has an average daily census of 2, and they keep begging the governor for money. And I'm turning that into an ED, a super ED, converting that. So the first one had no jobs. I'm creating jobs. The second one, we're going to dramatically restructure it. The third one is the most interesting, Denny. The third one is run by an operator from Texas who bought a bankrupt critical access hospital that had an average daily census of 3 patients. It now has 23 patients, average daily census, and printing money after 2 years. So you ask him, like, what did you do? Like, how did you get all those additional patients? He said, it's very simple. The care here sucked so much, everybody was going across the border to Texas to get care. So it was very simple. Rebuild the hospital and make it more capable rather than less. And then I said, well, aren't you worried if you partner with me, I'm going to take away your patients? He said, no. Now I could do ED at home. I'm going to go into other communities and steal even more patients. I'm going to take patients away from Texas. I'm going to basically grow volume. So Denny, looking at those examples, what you really have is excellence in care with great reach is going to start to destabilize inefficient facility-based care models, which will force a restructuring of the care delivery system in the US, and that's what's going to happen. Those that don't want that to happen are going to try to defend kicking and screaming, getting more resources, financial and otherwise, to fund their inefficient operations. In the meantime, those that are full, like many in Boston, will continue to use our kind of model to get case mix index up, get more capacity without building more towers, and they'll prosper financially. But in the end, we're overbedded in the United States by, I don't know, 30%, 35%, costing at least $200 billion. So it's Darwin. In the end of the day, it's Darwin.
Well, it's an interesting comparison when you think of, for example, what countries who have had to develop health systems who lack the kind of money that drives the kind of capacity building that you described. Take Cuba, for example. In Cuba, you have a community-based doctor who is essentially the connection between everyone who lives within, walking distance of that individual and the quote-unquote health system. We're seeing, a number of ways in which people and institutions are being creative about distributing and moving things closer to the patient. One of the things that is fascinating to me here, though, is the the idea that we can move eventually away from this kind of tower on the hill model, where everyone has to go to this big place, to a place where people are cared for more directly. There's going to be big changes in the way physicians and other clinical professionals practice medicine and nursing. Could you talk a little bit about what you're seeing, primary care physicians coming out of medical school, coming out of residencies, whether they're internists or OBGYNs or family practice physicians? This opens up a whole different way to practice. Can you talk a bit about what the physicians who have been a part of your work have experienced in terms of the quality of their work?
Yeah, excellent question, Danny. So I'm very privileged in Boston. All of our docs are Harvard docs, and they all could have gone anywhere. I mean, and they all have MBAs too, by the way. So
they all graduated first in their class. It's very humbling when you walk into the room. It's
yeah. We have the good fortune of having some very, very capable clinicians, and they could have gone anywhere, done anything, been anywhere. And I always ask them, I'm in awe of the fact that we're able to get them and retain them. And they all say the same thing, including the docs I've met everywhere in the country. The model that we have today doesn't work. It robs us our time with patients. We're on an assembly line. We see a piece of the care. We never have the emotional, spiritual satisfaction of actually healing anybody anymore, unless we're a surgeon, a neurosurgeon, and we actually fix somebody's brain that was going to die. We're robbed of the reason we got into medicine. So here in this model, we're able to practice in a way where we get the satisfaction and feedback and have the time that we looked for when we went into medicine to begin with. So our model is very, very appealing. And I need to tell you, when I started the company, I had 2 engineer partners and 2 physician partners. And the physicians that were driving the clinical side of this were the thoughts and feelings that I felt spoke for so many clinicians, which is the lack of satisfaction you were getting from their job as a result of how the model became so payer-centric, so time-centric, so EHR-centric. It robbed them of the value they thought they were going to get out of being a physician. So we've responded to that in the way we've designed the model, and I'm very proud of that. And that's another whole story about, I almost actually became a physician instead of an engineer. But the global answer is we have not yet met a doctor under the age of 60, that's not fair, 55, that hasn't said, this is a way better model, I'd rather do this. Now, in fairness, we've insisted in Boston that our physicians try to do at least brick and mortar one week, virtual another week, go back and forth. We think there's a lot of value, both to us with them having bricks and mortar care experience, and both to the facility they're working for to have virtual care experience. And the two inform each other, Denny, in a pretty potent way. So I still believe the best physician is working in both systems.
Okay. One final question, unless others have ones they want to raise. Specialists like bundled reimbursement. When it comes to, for example, orthopedic care or cardiac care, and this is an approach that seems to fit very well. If I were a surgeon, or if I was a physician and I was accepting in a direct contracting model full capitation for the patient I'm caring for, the opportunity for me to make sure the hospitalization is used only when hospitalization is essential, and that care at home be managed in a comparable way as you've described, would give me a great deal more confidence in the prospects that my patient will heal well and will be able to return to work or return to life as they did before. Are you having conversations, or are you seeing people talk about this in the context of, capitated reimbursement, bundled reimbursement for episodes of care, where, swapping this for 3 days in the hospital is not only an economically enormous lever for changing, what happens at the end, but clinically could have significant improvements relative to, say, the nursing home or the post-acute facility. Talk a little bit about that.
Yeah, that's one of my favorite subjects. So I'm going to give you 3 examples. They're all very worthy of paying close attention because they all provide insight to where I think this is all going. So I'm very close. The guy who runs the American College of Cardiology is a colleague, friend. I've spoken frequently at their events, and they're moving now, especially for interventional cardiology. They're moving to bundles, particularly direct contracting with employers. So in a cardiology context, Denny, when you take full risk on a catheterization, as an example, you're usually at risk for everything related to that catheterization. If you take full risk as an oncologist, 70% of cancer patient admissions have nothing to do with cancer. There's COPD, CHF, et cetera. So you take a full risk bundle for Medicare, as an example, a bundle payment program, and all of a sudden your patient is hospitalized for heart failure. What are you supposed to do? You're screwed. So the amount of oncologists that actually want to do bundle payments have shrunk to almost nothing for that reason. Right. And nobody knew that going in. And all of our patients who are cancer patients, all of our heart failure patients that have cancer, we've been doing that from day one, and we recognize where that risk corridor is. So one argument is, depending on the specialty, bundles make a ton of sense or they're scary, like with oncology. Second point, in the BPCIA program, are all your members familiar with BPCIA?
Why don't you describe it for those who might not?
It's a federal program from CMS where they create bundles where they say, I'll give you a great example. In Florida, if you're a hospital and you want to take a BPCIA bundle payment for heart failure, we'll pay you $35,000 and you have to be responsible for the patient's cost and care for 90 days. That's a typical BPCIA bundle. That $35,000 ranges city to city, state to state around the country based on Medicare rates. So you go in and you dissect that $35,000. You would think the hospital would say, terrific, I can make so much money on that. Well, first, Medicare required that the hospital have a minimum 2-day length of stay in the hospital, 48-hour midnight rule. So now I'm in the hospital for 2 days, and as far as the hospital is concerned, based on what their accounting says, that's going to cost me $10,000. So now what I really want to do to make sure that patient's not hospitalized again, first of all, I want to get them out of there as early as possible and stick them in a SNF. And I think I'm actually going to save money by, instead of keeping them in the SNF for 15 days, I keep them for 10. Well, sure enough, the 10 in the SNF, the 4 in the hospital, patients didn't recover, so now they're back in the hospital for another $10,000. I got 10, 10, and 7,500. Now we're at 27.5. Post-acute care, monitoring, social management, you're at 35,000. Oh, I know how Medicare came up with 35,000. That's what it costs now because I have a shitty delivery system that doesn't work. Now, imagine the patient has heart failure. We take them home and we care for them at home for 90 days. The total cost on the worst possible day is $18,000. No matter what I do, I can't spend more than $18,000. I got a check for $35,000. The margin on that bundle is higher than anything I'm doing in the hospital other than maybe cancer surgery or orthopedic surgery. So why isn't the hospital doing that? They're starting to do it. But when CMMI came up with the bundles, they didn't really imagine changing the way we delivered care. They tried to manage the existing care delivery a little bit better. And who wants to take risk on optimizing a system that doesn't work well, which is why the participation rate in bundles is pathetically low. We're advocating to go after bundles using the home-based model, and the economics of that are very compelling, and it's going to change the rules of how bundles are designed. And I'm fairly confident within 2 years, the entire bundle design is going to be shifting towards the home-based model, which takes me back to oncology. If a team of oncologists and cardiologists was managing the oncology bundle, now you're talking about taking risk. But unless they're paired, there's no way you should reliably take risk on an oncology patient who's going to be hospitalized for something else. That's my 3-minute education on bundles.
Well, let's step away from reimbursement for a moment for one question about technology. There's a lot of reliance on the internet, on the cellular, infrastructure, and you have a lot of remote monitoring tools, and you have a command center that's connected to a lot of homes. And in some of the geographies you're talking about, some of these people are far apart. Logistically, but also technically, how do you, what is your portfolio of remote monitoring tools that you need to have? And what type of networking requirements do you need to have? And you mentioned at the onset backup. What does that mean in the context of the internet or the cell signal or some of the, you know, the over the air, the over the ether connectivity that you have to have in order for a model like this to work? How do you mitigate those risks and manage that technology at the same time?
So I have, by the way, Danny, thank you for asking that question. It's probably one of the best questions to ask for this group. So I have a whole team that I'm managing in Oklahoma specifically and only focused on this because, as you would imagine, in rural Oklahoma, connectivity is an issue. In certain parts of the most rural parts of southeastern Oklahoma, which are run by Native American tribes, there isn't a member of that tribe that doesn't have high-speed internet, remarkably. And they finance that with casino money, as an example. And there's a lot of casino money in Oklahoma. Another example is every church that I've been to in the remotest areas of Oklahoma has internet access. I don't know if it's because they have a direct connection to God or they picked that site because they needed internet access to get to their parishioners. The third example is for some of my vehicles, I put a satellite dish on the vehicle, but that only creates intermittent access to the patient when the vehicle arrives. So, and then you have Elon Musk and the low-level satellites that are moving more and more closer to the part of the United States that we're going to be able to have 24/7 internet access at high speed. That's about a year away. When I add, do I move the patient to where the signal is? Do I bring the signal to the patient with the truck? Do I work more closely with the Native American tribes to get that signal there? Do I wait for Elon Musk to come to POTA? All of the above is what I'm doing. All of the above. If there's a landline, can I use copper to actually get most of the data I need? The answer is I can. So a combination of all of the above we're working with, and also have very significant grants. And we're working with Viasat in the state of Oklahoma, with a big satellite provider. Most of the connectivity in the airplanes now are provided by Viasat. So all of the above is the answer. But I'm very confident, Denny, within 24 months, which is a blink, we'll have this thing nailed, at least for rural United States. But internationally, it's a bit of a different story.
All right. I don't see other questions coming across the transom, and I've asked the questions that I see, and I've asked the questions that I have. Are there any, sort of final comments that you'd like to share with us? And we would really like to talk to you, have you come back and share with us your experience in maybe 12 months time.
I think Denny, just based on your audience, can I just take 2 minutes and tell you guys a quick story that should have relevance to your audience?
Sure.
So I'm an engineer, and I've never been an IT engineer. I used to build factories and equipment and machinery and redesign. I'm a process control engineer. So I never really had anything in my portfolio of experience that I'm proud of that looks like IT. So this is a true story, and it happened in Brookline. So I was getting a haircut 2 years ago, minding my own business, and I got a phone call from Fox News saying that Amazon just announced that it's going to create a new product and business model to monetize data from electronic medical records. And would you be willing to comment? Well, first of all, Fox News calling me is hilarious. Second of all, while I'm having a haircut, doubly hilarious. Thirdly, I don't know anything about what that means. I have no idea what that means. So how can I possibly comment on that? So I was perplexed, and I was actually laughing, and I said, I'll call you right back. And then I called our PR firm, and that day we actually hired our CTO, Will Crawford. I don't know if you guys know Will, and Will used to work with John Halamka back in the day. So I said to Will, I just got this inbound from Fox News, and they want to know my comments about Amazon monetizing electronic medical data. I don't even know what the question means, Will. And he goes, I do. And he hadn't even started working for us yet, Denny. So I said, just do me a favor. I'm getting a haircut. Write the answer. Send it to me. I'm going to forward it to Fox News. And I thought the chance of it being cogent, causing me to be on air, would be zero. Anyway, he sends it. I don't even know what it means. And I forward it to Fox News. 2 minutes later, the producer calls me, still getting a haircut. You're on the air tomorrow morning at 7:15, right after Steve Mnuchin, the Secretary of the Treasury. So I wasn't happy. I was scared shitless because I'm going to be on the air and I don't know anything about IT, nothing. So I did what I used to do in college. I got a hotel room across the street from Fox News in Manhattan, and I took out every book and magazine, and I created a bunch of index cards and studied up on every possible question. I watched like 15 episodes of Fox News. This is Marie Bartonova, the morning show, business show. And I'm preparing myself, and I literally had 7 cups of coffee, did not sleep, stayed up all night, and I walk on to the set. And there's Steve Mnuchin, and that's even more intimidating, much more intimidating than not knowing anything about IT. So put on my makeup, mic me up, and I'm going on the set, and they're in commercial, and it says 60 seconds, and it's counting down, and I felt urine going down my leg. I was so scared. And I've been on TV a lot, and I'm a good public speaker, but not when I know what I'm talking about. So anyway, everything I memorized, I forgot. I was so scared. I literally forgot everything. So I thought this is going to be the worst professional moment of my life. I get on the set, and the woman at the end of, if you've ever watched the show, there's 5 people in the panel, and Maria Bartolova on the end has a woman in a black dress, and she's aggressive. And whenever guest comes on, she's kind of the anti-guest. She's the one that's pounding aggressive questions to create controversy during the interview. So I see her first, and my stomach sank. And she looks at me and she said, "Mr. Rakowski, my sister has been in the hospital 3 times this year. She has cancer. Each time she got an infection. I fucking hate hospitals. Tell me what I could do to help you during this interview." And then the guy next to her said, "My aunt, same thing." And then Marie Partenova, same thing. So I start smiling. I do the interview, which you can Google, and they never asked me a single question about IT. They asked me questions about why patients should be at home instead of the hospital. So when I hear the word IT, all I think about is that haircut in Brookline, cramming for this IT session that never happened, and being lovingly cared for and interviewed by Fox News, which is not my favorite news channel, to put it mildly. Anyway, that's my ending story for you guys.
Well, I want to thank you, Raphael, for your presentation today. And I hope those of us who are in IT and data can have a comparable, if not as scary an experience as you've had because of our work. But this is very exciting. I think what you're doing is a tremendous extension and enhancement of healthcare. And you're working with some of the best people in the business to do it. So I want to thank you on behalf of the consortium, on behalf of our guests, our members. And we look forward to having you back when you hit your next milestone.
Just say when. We'd love to.
And we wish you well, and we will adjourn for today. Thank you, everybody.
Thank you, everybody.